and welcome to the Raising Kellen podcast. My name is Marsh Naidu, and I blog at raisingkellen.org, where we curate resources for families experiencing disabilities. I am super excited to say that over the next 3 sessions, we are going to be focusing on healthcare advocacy. On today's episode, I am joined by Dr. Beth Bowden-Seiler. Beth is a project director in health research and insights practice area, and her research is centered or concentrated on health care affordability. Beth, welcome to the Raising Kellen podcast.
Thank you for having me. It's great to be here.
You are doing some incredible work leading research that is centered on healthcare affordability, not only specific to Tennessee, but also looking at healthcare affordability and how it affects consumers in several other states, Beth. But before we delve into the research side of things, just so that we can make the connection with our listeners, would you kindly give us a little bit of your backstory?
Yeah, that's great. I don't often get asked about my backstory, so I'm happy to share that with you. Yes, I grew up in a very small town in Michigan. I have been born and raised in Michigan my whole life. It's about 3 hours north of Detroit in a very small town called Ubly. Went to school and graduated with about 65 people, and then left Ubly to go to college and ultimately graduated from Western Michigan University. I spent about 16 years in the College of Aviation at Western Michigan University doing human factors research, looking at the connection between pilots and the automation in aircraft and things like that, especially student pilots, because at Western Michigan, that's what we were doing is training pilots. I had an opportunity at that time while I was getting my master's and doctorate to cross over industries between aviation and healthcare and look at some simulation techniques that aviation uses, like checklists and things like that, and how they can be used in healthcare. And I found that work to be incredibly valuable and incredibly insightful, that research. And so once my doctorate was finished, I ended up leaving Western and coming to Altarum to develop more of a healthcare research background, because I just found that to be so beneficial and so valuable in what I was doing. When I got to Altarum is a nonprofit organization that it focuses on improving the health of individuals that have fewer financial resources, those that are really disenfranchised by the system. We work on behalf of federal and state and philanthropic organizations, and we work on not only the research and evidence base, but also planning and implementing different strategies to address healthcare affordability. My colleagues work in community health, and they cover things like maternity and child health care. They cover behavioral health, food and nutrition health, sexual and reproductive health. I am the senior manager of our health economics and policy program area underneath our health research and insights division at Altarum. And so a lot of my work really focuses in on that value of healthcare, what we get for the value of healthcare, the health outcomes that we see there, the return on investment that folks are making in programs, to see, what levers can we pull? What information can we provide? What evidence can we provide to decision makers, states, and even federal decision makers on programs that can really impact health outcomes as well as healthcare affordability?
Beth, just as a side note, right? So the U.S. spends about 17 to 18% of our GDP on healthcare.
Yeah.
And yet our healthcare outcomes, and my area of concentration is maternal and child health and mortality rates does not par well when compared to other developing nations. So when you speak to the work that you guys are doing is incredibly important because it is showing value-based care, and for where the money is going to, does that correlate to the outcomes that's been achieved in terms of health? But what's incredibly important as well, as far as your organization, Altarum, is concerned, can you speak to the objectivity in terms of how does the research get funded to kind of then support the policy? So can you speak to that, please, Beth?
Yeah, so specifically, the CHES survey is funded by Robert Wood Johnson Foundation and Arnold Ventures, and they're philanthropic organizations that really have a keen eye towards health outcomes and health affordability in the United States. Robert Wood Johnson is the one that funded the survey in Tennessee, and so we provide the data, we provide the evidence, we provide the perspectives that respondents in Tennessee have shared with us. And we do that in a way that is very evidence driven, but not advocating one direction or the other. You all know your state, you know what is palatable in your state, you know what you all find important and what value you place on things. And our job is to just provide that data for you. Our job is to provide the evidence in a very clear, robust way that can be defended, to say, this is what it is we're seeing. This is what we're hearing. We're not making predictions that people are likely to ration their medication. What we're saying is that these people did ration their medication. We're not projecting things. We're reporting what was reported back to us in a very evidence-driven way.
So the survey that your organization has conducted and that you are leading is called the CHES survey. Please tell us more about this to educate our parent advocates out there that are listening today.
Yeah, so the CHES survey stands for the Consumer Healthcare Experience State Survey, so CHES. And we named it that since 2018 when we started the CHES, because we've kind of felt like the healthcare system can be a lot like playing chess. It's difficult. It's difficult to navigate. What the CHES asks about are respondents' experiences with the healthcare system. Not only their experience in navigating it, their confidence in being able to navigate it, what they have experienced in terms of affordability burden. Have they had to make trade-offs in terms of trading off food or housing or basic necessities in order to pay for a medical service or medical procedure or a test or their medications? Whether or not they're worried about affording medical services both now and in the future. We ask about their levels of trust and respect in the system, how they feel they've been treated in the healthcare system. And then we ultimately ask about policies that could be adopted to curb some affordability issues and their level of support for those policy issues. And then we're able to take that survey and those responses and cut them by several categories. So if we wanted to, and we do, look at households that have a disability in them, and we traditionally find that those households have much higher rates of healthcare affordability burdens that they've experienced, worry about affording healthcare both now and in the future, rationing medication, foregoing care, going into debt because of healthcare services that they need. So we do find that those households experience that much more often than households that don't. We see that oftentimes communities of color experience these things more so than white, alone, non-Hispanic families. And so we're able to take a look at those different variables that we ask about in different categories as well. And we think that's really important for states to understand that these groups of people are experiencing burdens at a different level than what other folks are.
You provided a three-part webinar. You collaborated with the Tennessee Justice Center, in which you talked about healthcare affordability as well as worry for Tennessee residents that, that could not afford, or how they were managing their burden as far as trying to source healthcare and their access to healthcare. And one topic that was discussed was medications itself, and perhaps the rationing of medications that came up. As a researcher, can you perhaps tell us about some of the implications of that you're deducted from the survey on what rationing of medications could lead to?
Well, our survey provides the evidence behind how often this is happening. There is a lot of research out there that shows what happens when folks ration their medication. When we say rationing medication in our survey, we mean folks that reported they've skipped doses of medication, or they've cut pills in half, or they just haven't filled a prescription, and all of that due to cost. So that's what we mean when we say rationing. There's a lot of research out there that shows when folks do that, they prolong some healthcare chronic condition. If they have hypertension or diabetes or whatever it is that they may be taking their medication for, they prolong that, and they can really start to get into a downward spiral in their overall health, because they're not staying up with the medications that they need. They're not feeling well. And then when you don't feel well, you don't feel like going to work. And then so you may have lost work days or lost wages, and then your quality of life, right? The medications are there to hopefully help you maintain a quality of life that you want to maintain. And when you're not able to take those, when you're not able to take them regularly, when you're not able to take them as prescribed, all of those things can lead then to a worsened quality of life and overall health.
On the third part of the webinar you did with the Tennessee Justice Center, you kind of concentrated more on healthcare affordability concerns with as far as seniors and individuals with disabilities are concerned. Can you perhaps speak more to that on the podcast today?
Yeah, of course. So, as I have kind of mentioned, that we find that households that have a member in them that have a disability often have higher levels of healthcare affordability burden. And in that burden, what makes that up are components of foregoing or skipping care due to cost, having a financial burden, using up all of your savings, not being able to afford food or housing or basic necessities, maybe having large amounts of credit card debt because of the medical costs that are needed. These households tend to ration their medication more. These households tend to worry more about losing health insurance, about affording health insurance, about affording costs of a serious illness or an accident that may happen. They worry more about affording their prescription drugs. And so we can see that these households are compounded on what is actually happening in their households with their disabled member, and then having all of this financial worry, this burden, this affordability burden compounded onto that family, right? So we see that often happening, and that's not unique to Tennessee. That is in every state we have been in. The households that have a family member with a disability in them have much higher rates of reporting these burdens and these worries that compared to households that don't. We see they are more, they report more medical bills overdue. They report having medical bills that are currently overdue. than households that don't. We see that they report things like needing a medical assistive device but not getting it, and whether that's a cane, a wheelchair, or some sort of assistive device for them that they've chosen not to get because they can't afford it, or the cost of it, even with the insurance, is too high. And I think that's a really important point, is that we also look at insurance type when we look at these affordability burdens and problems. We often see folks that do have insurance that are still foregoing care, that are still experiencing financial burden, that are still rationing medication because the copays are too high.
Oh, Beth, I know it. That is so true. That is so true. And
Yeah.
that's what I wish folks could really understand. Folks, that actually the co-payments is what is a deterrent sometimes. Sorry for interrupting, but I just had to say that. Yeah.
Yes, no, exactly. So it's not something that folks without insurance are experiencing. It is oftentimes folks that are fully insured that still choose not to have a procedure done, or not to have a test done, or change the type of procedure or test they're going to have done because of the cost that they would have to, the out-of-pocket costs they would have to pay. It's just not something that they can afford. We have an option in the survey to provide what we call open-ended text questions. So what that means is it gives the respondent an opportunity to just tell us in their own words what it is they have skipped, kind of what that has meant to them. And when we look at those open-ended questions and we analyze them for what kind of themes are we seeing there, we often see it's dental services, it's mental health services, it's specialty prescriptions, these things that aren't common and aren't necessarily day to day. These things are the things that folks are skipping, that they're just foregoing, that they're just making decisions not to do, even if it would improve their quality of life, even if it would improve their situation. Financially, they can't afford to have the procedure or have the test.
There are a lot of parent advocates that listen to this podcast, Beth. So my question is this: how would you like to see the research, like the CHES survey, being utilized by our parent advocates, our listeners, our healthcare providers that support this community? What would be ways that the survey could be utilized and carried forward?
Yeah, that's a great question. I think that for us, the best use of the survey is the briefs that we produce, the information that we produce, to use them to educate folks, to say, look, we are having these issues in Tennessee. This is something that we should be addressing. We have a section I talked about earlier on the policies that folks support. And we often see, and Tennessee is not unique to this, that it really doesn't matter if someone is a Democrat, Republican, Independent, that across the board, people support policies to address healthcare affordability issues. Things like capping insulin or life-saving medications at a certain price so that everything is affordable. Things like ensuring that health insurance is affordable for everybody, that everybody gets quality health insurance and they can afford quality care. I think educating, using those briefs and educating the people that they're talking to say that this is happening in Tennessee. We say we have this evidence that it is, and that we're really not that far apart. I think oftentimes the hardest part is to find some common ground, and there is common ground in this topic. There very much is common ground here. Folks would like to see this addressed. The how to do that can be conversations for your advocacy organizations and your folks to talk through how that should be done. But the fact is that there's common ground there for healthcare affordability to be addressed, and our survey can point to that evidence. I think using it in that way to help educate and to help point to a objective way to quantify what's happening here is really ideally what we like to see the CHES used for. We've seen the CHES cited in legislation. We've seen it cited in court cases. We've seen it cited in several different venues. And I think that is, really rewarding to us, is to see that our evidence is being used in those ways.
So please correct me if I'm wrong, because I want to make sure that I get this 100% right. The CHES survey can be used to support that there is a need for discussion regarding healthcare affordability. It's just not I think or I feel this way. It actually is, there is a need, and it's been substantiated by this research.
Yes,
Okay.
That's exactly right. That's exactly right.
So the work perhaps now would come in taking the research and having the conversation around how can we advocate, or ways in which we can address healthcare affordability and policy that would support healthcare affordability. Your everyday person just wants to see some kind of solution or some type of needle moving in the direction of affordability, because it doesn't make sense for a amazing nation, for a wealthy nation, not providing this basic necessity. So having said that, Beth, what exciting research do you have perhaps planned for the future? And just really curious about that.
Yeah, so we have run the CHES survey in 36 unique states in the US, but we haven't ever before aggregated all that data together, and we are currently doing that right now. Hopefully in the next couple of months, we will have a national data set made up of the 36 states that we've worked in, to be able to look at benchmarking against everybody else. So we would be able to say, Tennessee, here's where you're at. And that's important for you. That to know where you're at is very important. But it also might make sense for some folks to say, but I want to know where I am in comparison with other states that you've run. And now we would be able to do that. Being able to aggregate this data set allows us to do that. It creates a much larger data set for us to run additional analyses on, to do some of that likelihood of experiencing an affordability burden. So we would be able to more robustly say families that have a disability, or have a person with a disability in their households, are more likely to experience these things than not. Right now, what we can say is that they're reporting that they're experiencing these things more than households that don't. But having this larger, more robust data set that covers across the country allows us to do deeper analyses there and make more statistically significant statements about the findings.
Where do advocates source the information the findings provided by the CHES survey, and what is the resource that we can go to find the findings?
Yeah, so we have a website dedicated to our work. It's called the healthcarevaluehub.org. And that's where you'll find all of our work around the CHES survey. We do some other work around policies, looking at policies, and it's called our Affordability Snapshot, that looks at each state in terms of what kind of affordability policies they have already implemented and passed. And then we have some publications on there as well. In the CHES landing page, you'll find all of the states that we have worked in, a map that shows all of the states we have worked in. And then each of those links will take you to a landing page that has the briefs for every state that we have been in.
Beth, Thank you so much for your work and thank you so much for your time. It is indeed a exciting time as folks seem to be coming together and moving to find answers and solutions for health affordability here in the United States. So just again, thank you so much for your time. And once those data sets are aggregated, we would love to hear back from you if that's possible.
Absolutely, would love to. Thanks for having me. It was such a pleasure to talk with you.
Oh, you as well, Beth. Have a great day, okay?
You too. Bye.
Bye.